Okay, we're back. Let's get this on. There we are. Okay, so we've talked about in the last couple of slides the impaired production of red cells for various numbers of reasons, and through blood loss is one of the main ones. And now we're going to talk about premature destruction. So that also causes anemia. And here we go. We can have from bone marrow suppression, premature destruction of red blood cells. Hemolysis is any breaking down of red cells, because there's the heme, that's red. A lysis is a breaking down. Shortened lifespan, anything less than 90 days. Normal is anywhere from 90 to 120. You can have increase in LDH, diminished haptoglobin, increased bilirubin. Spherocytosis is like an autohemolytic anemia. Cells are sphere in shape instead of biconcave or disc shaped. A diminished G6PD. Sickle cell anemia and thalassemia are two of the most common out of all of these. And there's our sickle cell anemia. Our hemoglobin S tends to crystallize or sickle the cells. That is not any gene anyone wants to have, whether you're a carrier or one that actually gets the disease. There's obstruction of small blood vessels. They're not the size they're supposed to be. They're sickled and very tiny and thin, and that's why the cells and tissues are lacking oxygen. Severe pain for these people, because blood obviously is systemic, and so these sickled cells are systemic, and so they have ischemia everywhere. Thalassemia is hemoglobin's normal, but there is a diminished hemoglobin production. So in these, the cells are fairly decent size, but we're missing the hemoglobin. So again, a form of anemia. And all of this has to do with premature destruction. Key points to remember with anemia: if any of the components are low, we have anemia. They don't all have to be low, but if one of these components is low, we have anemia. So if decreased hemoglobin, that's HB. Diminished hematocrit, which is the percentages of red blood cell in an area, we have anemia. And if we have diminished red blood cells, usually that's through a hemorrhage or a bleed, we have anemia. It's not a diagnosis, it's a sign of an underlying problem. And that's why we have to be able to decipher what we're looking at in a CBC. And it must be worked up to find out what the cause is. What's causing this? A hemogram evaluation of anemia. Here you can see in the top one, iron deficiency anemia is the most common worldwide. GI bleeds are more common in women because, again, of heavy menstruation. And you can see that they're a smaller size here. And then pernicious anemia, they're ginormous. They're just missing a lot of hemoglobin in pernicious anemia. It's a condition in which the body can't make enough healthy red blood cells because it doesn't have enough of the vitamin B12. And we know it's a nutrient found in some foods. The body needs this nutrient to make healthy red blood cells and to keep it, again, the nervous system working properly because it's a vitamin B. So people with pernicious anemia can't absorb enough of the vitamin B12 from food, again, because they're missing that intrinsic factor, which is a protein made in the stomach. Other conditions and factors that can cause a vitamin B12 deficiency are infections, surgery, some medications, and a lot of times diet. Hemoglobin and hematocrit proportion. Multiply hemoglobin times 3, and you usually have the appropriate hematocrit. So if we have a 10 hemoglobin, we have a 30% hematocrit. A 12, a 36, 15, again, would equal the 45% multiplied by 3. A good rule of thumb is 1 unit of packed red blood cells, that's what that P means, packed red blood cells, will raise an adult's hemoglobin by 1 or their hematocrit by 3. So you can see if the hemoglobin is low, usually the hematocrit is going to follow also, is going to be low. There you can see they work hand in hand. And if they're extremely low, they may need 2 to 3 units of packed red blood cells to raise that hemoglobin proportionally to what's going on with them. Causes of high hemoglobin can be smoking, living at high altitudes, heart disease, anabolic steroid use, pulmonary fibrosis, polycythemia, causes of high hematocrit, dehydration, COPD, other conditions associated with low blood oxygen levels and elevated level of erythropoietin by the kidneys. And we also always know that's a response to low oxygen level in the blood. And that, red blood cells reflected by the mean hemoglobin and mean cell hemoglobin. Hemoglobin is the source of a cell's color. Hypochromic may indicate spherocytosis. Normochromic is a normal color, and hypochromic is a pale color. And usually that, again, hypochromic is going to be iron deficiency anemia. This is a normal blood smear, or that's what it should look like. The little kind of highlighted portion is of the cell that you can see. You can see through it. Normal size, color, and shape here. Here's a normal blood smear. Also, this is a real smear, so it looks a little bit more colorful, if you will. But you can see neutrophils gathered. Lymphocytes are the large ones, and then platelets are tiny, tiny, but they're floating all over the place too. A normal smear. Here is our poor sickle cell people. Oh gosh, it did not photograph that great. Mine's much bigger. But you can see they do not look like this or this. They're all sickled in their shape. Looks like a crescent moon. And here we go with the sickle cell again. Defective gene that codes for globin. If they receive the trait from one parent, they're a carrier. If they receive the defective gene from both parents, they get the disease. And so thank God it's recessive, because I've only seen one patient with this. Extreme pain. We could not get her from being in pain, 28-year-old, and it was very, very sad to watch. They produce this hemoglobin S, which is a faulty hemoglobin, which tends to crystallize, or it sickles our nice round cells. So they're supposed to look like number 1 here, and they all look like number 2. And they get destroyed by the spleen because it doesn't recognize the hemoglobin S. And they obstruct small vessels. They cause anemia, hemolysis, and infections. But it's a recessive trait. It would be an SS on the genogram. So that's a good thing. Pathophysiology of sickle cell: abnormal hemoglobin S in the red cell, which causes hypoxemia, decreased pH, low temperature, dehydration. Erythrocytes sickle, meaning they become the half moons. With persistent hypoxemia, sickled red blood cells regain normal shape and function if they go through compensatory mechanism, or they clog vessels and they cause infarction. To treat, we have to give them oxygen. They need blood transfusions with normal blood because there isn't a lot of fluids to help with the dehydration, the plasma, and so forth and so on. So it's a devastating, horrible illness, and the biggest problem is the pain. Macrocytic anemia, they're abnormally large. Ineffective DNA synthesis due to vitamin B12 or folic acid deficiency leads to prolonged development because it's waiting for them to develop, and hence a larger size. And this is our folic acid deficiency and our vitamin B12s. Abnormally large cells is what they look like. Macrocytic reticulocytes, they're not able to divide and mature, but they die prematurely. And that's one of the reasons they become big, is because that they're unable to divide and mature. Microcytic or hypochromic anemia would be our bleeding types because they're lacking the color that they're supposed to have, and they're very tiny. And then thalassemia, small pale red blood cells. Hemoglobin forms properly, and that's why a lot of the cells are lit up, but the defect causes a decreased amount of hemoglobin production, and that's why you can almost see through everyone on the slide with thalassemia. People with thalassemia have tons of iron. People with iron deficiency have low iron. Key points to remember: small cells and pale cells usually go together. Normal cells go with normal color. That's what we want. And large cells are usually normal in color. They just can't divide and function like normal red cell. Our RDW, our red blood cell distribution width, should all be about the same size. Normal RDW 11.5 to 15%. You do not have to know this number. It will be on a CBC for you to look at. Greater than 15% indicates that new cells differ in size, larger or smaller when compared to older cells, and they shouldn't be. They should all be about the same size. Size when released is size that they remain for life of the cell, a measure of how well the bone marrow is working. Clinical manifestations of acute blood loss. 500 cc's is 10% of the total blood volume lost. Usually none. Rarely notice vasovagal syncope in blood donors sometimes, or they may stand up real quick and may fall down. 1,000 cc's of blood loss is 20% of total blood volume. At rest is difficult, if not impossible, to detect volume loss. Tachycardia is common with exercise, and a slight drop in blood pressure with postural change. So you can kind of see, we can lose a lot of blood and still, compensate and be okay. 15%, 30% of total blood volume. Neck veins are flat and supine position. Now our volume is low. Exercise, tachycardia, and postural hypotension are usually present. And you can read the rest. 2,000 cc's would be 40% of total blood volume. These people are air hunger at this point. We can't really sustain much more than 1,500 cc's of blood loss and not be very, very symptomatic. And they're going into shock. They have a thready pulse. Blood pressure is dumping, and I'm sure tachycardic. 2,500 cc's is 50% of our total blood volume. Severe shock, lactic acidosis due to the lack of oxygen in the cells, and possibly death. So just to give you some markers on that. Intervention anemia, number one, we got to treat the underlying cause. And that's why that CBC and those slides of what the red cells look like and the history from the patient is very, very, very important. We have to replace the needed micronutrients. Iron multivitamins will increase in reticulocytosis. And then epoetin or Procrit, helpful in severe anemia, particularly in the presence of kidney disease. Okay. What could this be a cause of? What do you think is going on here? We've got normocytic anemia, which basically could be a sudden blood loss or chronic disease. Here. This could be malignant neoplasms, chronic infections, or chronic autoimmune disorders such as kidney failure. How about this one? Where this one, all the indices were normal, but the red cells were low, and that's why we would have sudden blood loss or chronic disease. This one, everything's low. What could this be? Even low iron levels, maybe. Iron deficiency, anemia, chronic blood loss, because everything's low. Or a lot of common cause in younger women will be heavy menstruating, intestinal bleeding, or if we've got a slower bleed from tumors and ulcers. But this one with everything's low is going to probably be blood loss. I'm going to stop now because I think this tape is going to stop. I'll be back with the very end of this.